So before starting, may I know to whom will I hand over the session after the introduction?
Dr. Bijan Saha will be today's speaker for this topic.
Okay.
Sir has
So,
already joined the group.
yes, right. So, with all your permission, we're beginning today's session. Good evening and a warm welcome to all the dignitaries present here. I am Shweta from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet stands as most relied upon digital platform offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarnet serves as a digital partner for this event hosted by National Neonatology Forum, and the focus of today's session is NNF Shine Week 4. It's so. So without taking any further time, I would like to hand over the session to Dr. Bijan sir. Over to you, sir. Kindly proceed, sir.
Thank you, Shweta. Good evening, everybody. Good evening, everybody. As it is likely said that this week is the fourth week of our new NNF Shine program. Today, what we are going to discuss, we are going to discuss on developmental supportive care and kangaroo mother care. So let me share my slide. So, just let us start the our discussion developmental supportive program and KMC. Before I start, let me tell you why this developmental supportive program. As all of you know that the if a baby is born to actually born in time, baby has to be born at 40 weeks of gestation. In neonatology, we have got two objectives in our mind. One is to reduce the mortality and to improve the neurodevelopmental outcome. A mother goes to pregnancy for 9 months just to have two things. One is they should have a good, healthy, normal, healthy newborn, and this newborn will have good neurodevelopmental outcome. But many a times it happens that sometimes babies are born preterm. As I said to earlier, if the baby is born preterm before 37 weeks of gestation or before 40 weeks of gestation, his brain is not developed. It is said that at 23 weeks of gestation, brain is almost smooth. And this sulci and gyri and fully matured by around 40 weeks of gestation days. Actually, if a baby is to born, baby is to born by 40 weeks. Second important thing is that when there is a development of the brain, there is fast arborization and proliferation of the neural tissue. Then there is synaptogenesis. And during this time, if the baby is exposed to any noxious stimuli, it adversely affect the neurological outcome. So it is said that in extrauterine environment, the infant is continuously exposed to numerous stressful factors. Healthy term babies are neurologically mature because, as I have told you, their sarca, gyrus, and this developmental process already is mature to adapt reasonably to environmental stress factors and adjust. But the babies who are born preterm or sick preterm infants, they can adapt poorly and it may adversely affect their neurological outcome or neuromotor development. So that is why it is our responsibility to show that this baby will have good neurological outcome so that there is some developmental supportive care program what is there. Now let us discuss what is developmental supportive care or DSC. DSC is an integrated approach comprising of set of do's and don'ts which are potentially beneficial to sick preterm infants to help them to cope with the adverse external environment of the NSU. Actually, it is a integrated care or program approach, and that can be which is helpful for their neurological development. And who can provide this DSC? It can be doctor, it might be nurses, it can be support staff, anybody. So it is another important thing is that to note here, every effort should be made so that the negative influence are to minimize the negative influence that are experienced by the baby can be minimized. So that is what is developmental supportive care program. Now let us talk what are the components of DSC. One of these are the core components of DSC. One is protected sleep. Second is pain and stress assessment of management, developmental supportive activities of daily living, family-centered care, creating a healing environment. You can add two other things. One is skin care and also nutrition. Now, many people say that there are 7 components. Here we have told 5 components, and in these 5 components, you will find skincare as well as nutrition. So these are the core components of developmental supportive care. So let us go one by one. How can we can ensure protected sleep? You can promote sleep by facilitated tuck, swaddling, skin to skin contact, nestling, and swaddling. As it is evident from the slide, let me tell you what is nesting. Nesting is a boundary. It's creating an intermediate environment so that baby feels secure. Second is swaddling. What is swaddling? Swaddling is that it is the wrapping of the baby so that the baby feels secure. Third is the facilitated track. Facilitated track means these babies should be flexed posture and should be in the midline so the baby feels more secure and baby can sleep better. So we should not confuse what is swaddling. Swaddling means covering the baby. Nesting means it is a boundary which is created so that it can have the feeling of intrauterine environment. Facilitated tucking is that the baby should be kept in midline posture and hand and feet should be flexed. So another important thing you can ensure sleep is a kangaroo mother care. We will discuss further in details in the later part of our slide presentation. Third important, the light and sound are minimized. But many times if you go across the unit, you will find there will be lot of noises, lot of alarm that is going on. People are speaking in a loud voice that disturbs the babies and hampers the baby's sleep. And day-night pattern is simulated. So what is our actually aim? We have to minimize the sound, minimizing the conversion in NICU. It is said that if you talk more in the front of the baby, that will disturb the baby. That is why in many centers, sometimes the actually round is taken in another room so that babies are not disturbed. Then addressing alarms in NICU. Here I want to say one thing that in most of the unit, if you see that alarms are going on, but the residents and the staffs are not actually are not aware of what is happening. Two important things to happen: that alarm should be set and also volume should be minimized. Volume should be set in such a manner so that you can hear the alarm and you can address. It should not be like that the alarm is so slow, so if there is an alarm, you cannot hear. So at the same time, we have to reduce the volume of the alarm. That's why it is our duty to teach each and every nursing staff, every resident, how to actually set the alarm limit, and you should know each and every alarm limit or every parameter, and also you can reduce the volume and act accordingly, and avoid corridor talking in the NICU. Second important thing is to prevent and treat pain and reduce the stress. How can you reduce the stress? The first is a cluster care. What is cluster care? You see in the if a baby LBW baby is admitted in a unit, there are a lot of processes you do. You change the diaper, you do sugar monitoring, you take the sample for bilirubin, you take sample for some other things. So always you should try to do so that all the processes, all the investigation can be clubbed together so that babies does not train frequently. Second important thing, whenever you are picking a baby, you should take the permission from the nursing staff. Why it is permission? Because when a baby is sleeping, we should not go and you should not disturb the baby. As I told you earlier, that protective sleep is one of the important component for DSC. So when the baby sleeps, suppose then you should not disturb. So all the process, all the procedures can be clubbed together so that it minimizes the number of attempts to a baby. Second is adhesive. I think many times we put adhesive to a neonate. It should be removed very carefully, especially who are born less than 1,000 gram or less than 1,500 grams. You will not realize what happens. Suppose a baby is some adhesive is given or the baby is put thermal probe is attached to the baby's abdomen. You will find many times the adhesive is taken out and there is a lot of redness and the superficial layer is gone. And after 3 or 4 days, you will find it is a portal of entry for the organism and baby is having sepsis. So that is why you should be very, very careful when you are removing the adhesives. Parents must be educated regarding infant pain. Why? First of all, I always feel that before educating the parents, we must educate ourselves, our staffs, our support staff, our nursing staff, our residents. We should actually be educated regarding that these babies feel pain more than us. Then there should be unit protocol to document and manage pain and stress. I'm not sure how many of you who are here, they are having document and some protocol for managing pain and stress. We have got a notion that these babies do not feel pain. That is not so. Babies feel pain more than us. If the baby is born premature, their pain sensation is more than the term infants. Use of both non-pharmacological and pharmacological measures prior to painful or stressful procedure. Some of the non-pharmacological process, I think you are practicing. One is gauze lollipop. This lollipop is dipped in the breast milk and you can put in the baby's mouth, that this decreases the pain. Second is that you can do the containment. Third is that kangaroo mother care and also breastfeeding. So if you are doing some simple procedure, you can do all these non-pharmacological measures that will reduce the pain. You will not understand actually why we don't appreciate that these are causing problem, because if you see that if you keep the baby on follow up on neurological neurodevelopmental outcome, you will know. But I think neurodevelopmental or follow up, neurological follow up is not that that strong in our practices. Another important thing is that we do not bother about this neurological outcome. We only bother about the early outcome, that is the mortality. But it is the not only mortality as well as morbidity, especially neurological outcome is important. Second, activities of daily living. I think this is one of the most important thing. What are those? Use boundaries to maintain them in flex posture. The position of the baby is very, very important. How to maintain the position. You will find many times you will go to the unit, your baby is in the bassinet and all the four limbs are exposed and they are in extended posture. This is a very bad posture. A baby cannot be kept like this, and that will cause some effect because of the gravity, and that will some cause permanently damage to the baby. So posture should be flex posture. The nesting swaddling should be kept so that the baby feels secured and the, it will not and the gravitational forces does not have any effect on this baby's muscle. Second is gentle handling. Why this gentle handling? Because in activities of development daily living, you should remember this tactile, vestibular, auditory, etc. When you are actually handling the baby, baby should be handled very gently so that this vestibular effect is not affected much. So suppose you are changing the diaper. Most of the time you will find when you change the diaper, you are lifting the legs. That is wrong. If you are lifting the legs, that means you are causing more stress to the baby. So without lifting the legs, you should change the diaper. So changing and with the movement and the posture is very, very important. And this is only possible if our staffs are actually aware of this is important. Unless you educate your staff, they will not realize the value of it. Next is the non-nutritive suckling. I think many of the babies, as you see, these are all, they may be on OG tube or in the case feeding. So when the babies are always feeding, but these babies should be given to the empty breast. How does it help? It helps for greater suck, more suck per burst. It will have good gastrointestinal transit time, and also it will reduce the pain. So non-nutritive suckling has got great effect in the activities of daily living. And mother should be encouraged to participate in activities of daily living like feeding, oil application, diaper change, sponging, etc. And I'm sure all of us who are here, most of us are working in busy NICU or SNCU. And busy SNCU sometimes staffs are inadequate. Even the staffs are adequate, we should educate or we should encourage our mothers or to actually participate in the daily care of the baby. How does it? It will actually it will empower our mothers for the daily care. Also, it will reduce the fear of the mother from carrying the babies, and mother will be encouraged to participate in the activities of daily living. Because many centers, the mothers are giving feed, they are applying application, they are changing the diaper, they are giving sponging. All these things should be taught. I think without teaching, you cannot allow a mother to do all these things. And before teaching them, we should educate ourselves so that they can do the things in a better way. Then family center care. What is family center care? Family center care is that you should encourage the family members to participate in the baby care so that they get empowered. This reduce fear of the mind of them so that they can handle the baby in a better way when they are going home. So it imparts skills and knowledge related to baby care to the mother and caregiver. So what are the things? Hand washing skills. In many centers, there are some certain infection control care nurse. So what is her job? Every day she will come and she will actually see all the mothers how they are washing their hands. They will teach the mother how to do the good hand washing skill. So once they are taught, they will better do the work in the better way. Importance of infection prevention. Because one of the important thing I always say that infection prevention we cannot realize, because if your organism enters the body and the circulation, it causes havoc in the body. Once we lose the way, then we understand. Because about how they are going, that we do not know. That is why you have to actually make them understand the importance of prevention of infection and control of infection. And protocol for entry to the nursery, because before entering the nursery, they should wash their hands. And also in between how to, and the 5 moments of hand hygiene should be taught to the mother. Why these 5 moments of hand hygiene should be taught to the mother? Because it is very important. I think all of you know what are the 5 moments of hand hygiene. One is before touching the baby, after touching the baby, before doing any procedure. Mothers are not doing the procedure before, after touching any secretion or body fluids, because that they are sometimes they are changing the diaper, and also before touching any baby's environment. Babies are many times it is touched, so that if we do not teach them, they will not understand. Then the other development of supportive care, what we have discussed till now, that can be also taught to the mother. And the kangaroo mother pair, it is one of the essence of family centered care. There should be taught each and every mother. We will discuss this further in detail in the later part of our presentation. And preparation for discharge and care at home. As I have told you earlier, it is very important because these are the preterm babies, they are going home, and when they are going home, nurses will not go to them with them. So unless they are educated and they are empowered or they are taught how to take care of these small preterm infants, they will not be able to handle this baby at their home, and they will do faltering, and many times you will find these babies are readmitted in our units. Then another important component is the healing environment. The first is a minimize sound and noise. Sound, how much sound? AEP says that at least in a NISO or SNC, at least 40, 45 to 50 decibel sound is allowed. So then, so one of the important thing, as I told you earlier, that we should not talk loudly in front of babies. There should not be closed door talking. Then the alarm should be, the limit should be, alarm volume should be low, so that babies does not get disturbed. Second is light. Strong light, it hampers the baby. That is why many times it is said that when a baby is in the cot, you can put some eye shield over the baby's eye so that the strong light does not disturb the baby. It is said that at least 400 to 600 light candle light is permissible. In daytime, it is around 100 to 200, and the night time it is 50 candles. And do not use procedural light unnecessarily. One of the important thing in the procedural light, actually, what you see, most of the procedural light, these are actually somebody stuck out. Procedural light is very important, and sometimes spot illumination light may be important. Somebody's please mute yourself. Please mute yourself. Hello, someone is coming. Actually, please mute. So practice of good care, behaving behavior such as adherence to infection control protocols. As I told you earlier, infection control protocol can be practiced, and some infection control nurse should be available, and their job is to teach every staff as well as mothers about the infection control. Any test result that is like unlikely to change the management is unnecessary and can be potentially harmful should be avoided. Promote healthy communication between the physician, nurses, and other professionals. This is very important because if we cannot communicate or connect the mother, nurses, and other professionals, then it is very difficult. And in the same minute, there may be some differences. I think we should work together. We should work in the same language. We should talk the same thing so that the parents or mothers are not confused. So, what is DSC? DSC is a continuous process starting at the birth, which has to be individualized for each infant, reduces stress, promotes growth, and provides mass needed stimulation of the developing brain. See if we can summarize by developmental supportive care, what are those? One is a protected sleep. How can you ensure protected sleep? Nesting, swaddling, kangaroo mother care, and cluster care. Healing environment, you should minimize the sound and light, maintain asepsis, facilitate smooth transition. Family centered care involves families in the care, counseling, lactation support, and educating. Activities of daily living. That is a flex posture should be maintained. As I told you earlier, if you keep the baby in extended posture, that is a bad posture. Another important thing is that non-nutritive suckling, as I have told you earlier, it helps in the baby for the better suck, better gastric changing time, and also reduces pain and feeding breastfeeding. Prevent and treat pain is non-nutritive suckling, swaddling, containment during procedure. Another important point to note that whenever you are making a nesting, what is the most important point of nesting? Nesting is that suppose a baby is small, so nesting should be in such a manner so that the baby should be inside the nest. Sometimes it happens that you make a nest and the baby's hands are out, baby's legs are out. Then it is not actually nesting. That means your nesting size is small. It should be made in such a manner so that the whole part of the baby should be inside the nest. Here are two other components that I have told you earlier that can be added. One is skin care and non-nutritive and also nutrition. In the nutrition, colostrum, non-nutritive suckling, and also oromotor stimulation is important. If the baby is born preterm, you give oromotor stimulation helps for the early enteral feeding, and also lesser use of parenteral nutrition, and also non-nutritive suckling that we have discussed earlier. And skin care is very, very important. I always say that you also believe agree with me, the skin is the largest organ of the body, and many times the skin is pricked. Another important thing to note is that whenever I see a baby after 2 or 3 days, baby is born, you find multiple pricks. What is this? If there are multiple pricks, that means you are already pricked too many times, and these are portal of entry. So one is you are increasing the risk of infection, and also you are causing obnoxious stimulus to the baby. So that when you are pricking a baby, you should be very, very careful, and every effort should be made so that there is no breach in the skin. Maybe it is adhesive remover, maybe it's procedure, maybe changing diaper, maybe handling the baby, etc. So skin care is also equally important along with these 5 components. Now, let us discuss another component, that is the kangaroo mother care. This is one of the multimodal approach to provide developmental supportive care. As I have told you earlier, the kangaroo mother care is one of the essence of developmental supportive care. Now, what is kangaroo mother care? Kangaroo mother care comprises of skin to skin contact. Skin to skin contact means not only skin to skin contact, it is the prolonged skin to skin contact, prolonged and uninterrupted. Second is exclusive breastfeeding, and actually there are 3 components of kangaroo mother care. One is prolonged uninterrupted skin to skin contact. Second is exclusive breastfeeding. Third is early discharge and follow up. We will discuss all these 3 one by one. Now let us discuss who are the babies that are eligible for kangaroo mother care. Our traditional teaching is that any baby born less than 2,500 gram and hemodynamically stable, these babies are eligible for kangaroo mother care. Just remember one important thing: whenever a resident is asked who are the eligible babies for kangaroo mother care, somebody will say less than 1,000 grams, somebody will say.
Sorry for the interruption, sir. The slides are not moving, sir.
Uh-huh.
The slides are not moving, sir.
It's not moving.
No, sir.
Huh? But in my see, it is going on.
Can you start the screen sharing 1 second, sir?
Okay. Now,
Yes, right, sir.
now it is moving.
Can you just move to the next slide once, sir?
Yes, sir.
No, it is not moving now.
It's moving now.
Just 1 minute.
So you have to use the arrow, sir.
Using arrow only. Now it is moving.
Yes, yes, sir. It's
So our traditional teaching is that less than 2,500 gram and babies are hemodynamically stable. But when you are asked who are the babies who are eligible for kangaroo mother care, somebody will say less than 1,000 grams, somebody will say less than 500, somebody will say preterm. It is not a gestation; it's the weight of the baby. Any baby less than 2,500 gram and hemodynamically stable, they should be eligible for kangaroo mother care. Here we have said that stable babies less than 2,000 gram need should be high priority for KMC, because in our day-to-day practice we find there is a high load facilities. When there is load is very high, in that case those babies who are born less than 2,000 gram, they should be given priority. But if you can provide the babies who are less than 2,500, then also you can continue kangaroo mother care for those babies also. So here it is given, here there is a stratification of the weight. If we know that any baby born more than 1,800 grams or less than 2, or they should be admitted in the postnatal ward and they are with the mother. And I feel maximum number of babies will be with the mother. So more than 1,800 grams, less than 2,500 grams, these babies can directly suck from the mother's breast. With this notion, these babies are kept in the postnatal ward. So most of these babies KMC can be initiated immediately after birth, but the priority will be given to the babies who are born less than 2,000 grams, and this can be started in the delivery room. If you want to start delivery room, then skin to skin contact should be started in the delivery room. We know that what is skin to skin contact. Skin to skin contact should be provided in the delivery room for all babies who does not require resuscitation. The same babies, skin to skin contact should be practiced at least 1 hour there, and that baby will be transferred to the postnatal ward with the babies in the mother's chest. So this can be initiated, and when they are going to the postnatal ward, that KMC should be continued. So here we have got the great responsibility to start KMC for all those infants who are in the postnatal ward. But unfortunately, we focus more on the SNSU rather than the postnatal ward. That is equally important. Second, babies, those babies who are born less than 1800 grams or more than 1200 grams, these babies, I think many babies, they get stabilized within 24, 48 hours. So once they get stabilized, that's because we have told that hemodynamically baby should be stable. You can start immediately KMC for those infants. Only just few number of infants who are born less than 1200 grams. I think it may be 2 to 3% of your babies in the NICU or SNCUs. They may have serious comorbidities or morbidities after birth. So this they should be allowed for camera mother care once they are stable. Then who can provide KMC? KMC can be provided ideally by mother. Any adult trusted by the parent can provide or foster KMC. Father, aunt, grandmother, grandparents, preferably the same person continues and should not have any infection, and also they are willing. Many times you will find when you ask the mother. So another important thing to note here, once a preterm baby is born, you will get busy with the preterm babies for many other things. But you forget to call the mothers in the SNSU or NICU. So it is equally important that you should allow the mother to come to the NICU or SNSU to see their babies, to express their milk, so that they can have feeling of the babies. But what happens many a times, suppose a baby less than 1200 grams or 1200 1800 gram babies are kept in 3 or 5 days. Once you call the mother, mother is not coming. You ask the nursing staff, nursing staff, oh, I am calling several times, she is not coming. So it is our duty to call the mother and counsel them so that they come regularly and they are willing. And many times the mother gets feared that baby is small, so I cannot handle. So it is your duty to convince the mother or counsel the mother so that the KMC can be started once the babies are stable. I think all of you know these are the benefits of the KMC. It reduces pain, better bonding, reduces hypothermia, reduces infection, it reduces mortality, it promotes growth, multimodal stimulation like the 5 senses. One is the touch. Babies are in skin to skin contact. Then vision. Babies and mother is an eye to eye contact. Then smell. Mother's breast milk is a boost stimulus for the baby, and baby gets the smell of the mother. Then vestibular. Then taste. Baby gets the taste of the breast milk. So it satisfies the 5 senses. So it is a multimodal stimulation, and it has got long-term benefits. So it has got short-term as well as long-term benefits. It is said that 65% of the hospital-acquired infection can be can be prevented. Hello? So what are the advantages of KMC? Mother's confidence and bonding is encouraged. They feel less stressed. Mothers are mothers are, mothers are empowered to play an important role in their infant's care. Breastfeeding is promoted, less neglect and abandonment. And I tell you, whenever you encourage the mothers, mother will have confidence and bonding is encouraged. Fathers are also able to play far greater role in the care of the infants. It improves bonding between the fathers and mother. There is a problem in some unit. They do not allow the father, but they allow the mother only family members. So if you are allowing any other family members, you can encourage them. If you allow father, you can encourage the father to for kangaroo mother care. Even the father cannot give kangaroo mother care in the hospital. They can continue kangaroo mother care at home. So how does it help? These infants get warm and stable. It improves mortality. Infants grow faster. Serious infection is less common in the infant, less apnea. So it has got all the benefits, and how the healthcare providers, fewer staff and less equipment are needed in hospital nurseries, and infants can be discharged home earlier, and it is cheaper. So these are the advantages. You can encourage the mother to tell about all these advantages, like it improves growth, it keeps the baby warm, they will have less infection. They can go home early. This is one of the great advantages of kangaroo mother care. I think many a times we discuss how what should be the duration of kangaroo mother care. One of our professors says that kangaroo mother care duration should not be mosquito dose duration. It should be at least 1 hour. Rather say it should at least 1.5 hours. So there may be short KMC 4 hours, extended KMC 5 to 8 hours, long KMC 9 to 12 hours daily, and continuous more than 12 hours. Now the question remains how we can ensure these 4 hours or 9 hours more than 12 hours. Because we know the mother comes every 2 hours for 3 hours. So if they want to have 8 hours at least, so at least in one shift they should sit in one sitting 2 hours. How we can ensure? Suppose in the morning shift you want to encourage the mother for 2 hours, then mother should have their breakfast and should have normal daily sports, and after that they should come to the NICU or SNSU they should sit for at least 2 hours. If you can keep this, and you should know when your breakfast time, when is your lunch time, when the lunch is provided, or the breakfast is provided, when the dinner is provided. Accordingly, you should have your timing in your NICU, and during that time, you should encourage the mother to sit. Sometimes I asked in my unit how we were encouraged 2 hours or 3 hours in one sitting. They say that in our public sector hospitals, sometimes even some mothers they bring their breakfast or lunch from home. So they take the breakfast or lunch early and they come early. So it is you can individualize, but thing is you should have some mechanism or process so that they can do at least 8 hours. Doing half an hour or 1 hour, it was of no use. You should encourage the mother and you should ensure that at least 4 hours or 8 to 10 hours KMC should be practiced by the mother. And duration should be counted as a cumulative quantity of hours during a 24 hours. You can give a chart and mother should write a chart. Sometimes we feel that they write exactly 1 hour. How it can be exactly 1 minute less, 1 minute more is not there. So they should exactly write the nursing staff should write the exact timing so that you can have the cumulative hours of PMC. So now one of the most important period what I feel is the counseling. I think this GALPAC, all of you are aware, G for greet the patient. So before putting the baby for KMC, you should counsel the mother. How you can counsel? You greet the parent first. How are you? What how it is going on? And after that, I will ask how is going on, how is the medical problem, any issues, any infection, what they feel about the baby. So you allow the mother to talk. Then whatever she says, you listen. One of the most important part of the counseling is a listen. And after you listen, then you counsel. Importance of KMC. You should individualize. How it will individualize? Because what happens, uh, suppose a baby is 2 days old, if you tell that importance of KMC and that baby is it improves weight gain. So third day you mother will ask, you have told me earlier that it will increase that today baby's weight has been lost. So it is said that in the first 7 days life, it is better not to talk about the weight. You can talk about the other benefits of KM mother care. And you should talk about how the hand washing, hand rub, etc., how it is done, how long they should do. So first counseling, first is ask, greet, ask, listen. Then P means praise. Praise means whatever they have done, you should praise. Suppose a mother has not come, then how can you praise? You can praise that at least we have come and we will now start KMC. You can tell the mother that, see, you have not practiced KMC, that mother is doing KMC. So if you do KMC, your baby is also grow up, grow in a better way. So that way you can praise. After praising, you have to advise. Advise not more, one or few. But because why you give more advice? If you give more advice, they will be confused. I remember one of our mother came to our OPD. So one of our residents were giving some advices, and suddenly mother told, "Sir, I have got the time for the train." So it should not be more. It should be very much specific advice. And after that, check. Why check? Whatever you have said, Rohita, how much they have understood. So we have to ask the mother, "What I have said, please tell me what I have said." So that happens in everywhere, in breastfeeding, even everywhere. So that is the process. So you can apply this GALPAC mnemonic in any counseling. This is a and simple mnemonic. And another important thing, as you have seen, you can do individual counseling as well as you can do group counseling also. And once you start counseling, other mothers will be encouraged. Then your work will be less. And once a practice is in place, automatically they will go on doing this thing. Then what are the requirement of PAIMS? I think all of you know training of the nurses, what we have told, physician, other staff involved in the care of the mother and baby. Educational materials such as information sheets, posters, videos of PAIMS in local language should be available. Reclining chair in the nursery, postnatal ward or beds at the tool back way should be encouraged, should be arranged. One thing should be noted here. Even without reclining chair, a mother can give KMC in the bed also. So it is not necessarily that every time KMC should be there. So we can start KMC even without reclining chair also. Mothers can be provided using any front open gown so that a baby can be put in a better way, even with sari or blouse, shirt or shawl. Baby should be dressed in cap, socks, diaper, and front open clothing. We'll show you a picture that will give more clarity. As you have seen from the slide, what is the KMC position? One is the face can be seen, head in the sleeping position so that there is no apnea, eye to eye contact, nose and mouth are not covered, head is turned to one side and slightly straight, not bent, well supported. Here, one thing to be noted, many times we'll find sometimes mothers stop doing KMC after 1 or 2 days. They said yesterday mother was doing KMC, suddenly there was apnea. So you have to see that whether the neck is either neck is not flexed or neck is not extended. So if the neck is hyperflexed or extended, there may cause some obstruction there that can lead to apnea. So these should be very, very careful. And once a baby throws apnea, next 7 days you might not get the mother for doing KMC. So that is why neck should be straight, not bent and well supported from behind. Shoulder should be flat against the mom, chest to chest with mom, preferably between her breast. Legs are flexed below the breast in frog-like posture that you know. Bottom is supported from the below as it is seen from the slide. Mother is little upright, not flat, and on bed and chair. Cover the back with blankets. Both are washed when sleeping, and babies is being monitored. So, if you want to actually establish kangaroo mother care, first kangaroo counseling, then give practical help, that is kangaroo position, and after that you have to monitor the baby. So these are the three components you want to do. One is first you have to counsel. Without counseling you cannot. Then you have to give some practical help how it is done. Then you have to monitor the baby. As it is said that it is the baby should be monitored every 15 minutes for at least 2 hours while the baby still remains in skin to skin with the mother for the pollen. One is activity. I think mother is the best nurse. She can do whether the activity is normal or abnormal or baby is not moving, baby is lethargic. Breathing. Mother can feel the air movement from the or the number of the breaths for a minute. Color. Normal color, baby is pink. Temperature. Mother, you can teach the mother the human touch technique how to check the temperature. If the mother say that both the abdomen and the feet are warm, that baby is normal. If the abdomen is cold, that means baby is in cold stress. If it abdomen and feet are cold, then baby is hypothermic. So, and position of the neck needs to be monitored. This is very, very critical because if the position is not in is not proper or is not the baby is not neck is not slightly extended posture, there may be more apnea, and that will actually jeopardize your KMC practice in the unit. Then discharge criteria, when this low birth weight or can be discharged. Infant is able to maintain the temperature and mother is confident to take care of the baby. Feeding by palada or direct breastfeeding and gaining at least 15 to 20 gram per kg per day for 3 consecutive days. No acute problems. Mother is confident of taking care. And gestation is more than 34 weeks and more than 1.4 kg. In some center it is 1.5 kg. That means one if the baby is more than 1. So it is, but ideally it should be more than 34 weeks, more than 1.4 kg. And at least 8 hours of KMC for 3 consecutive days. That is very important. And this has to be established in your unit. If you cannot establish in your unit, when they are going home, they will not be able to do so. Then ambulatory can be provided at home. I think if I am not wrong, in many communities still it is this practice is still there. Even the bigger babies, children are also kept in this portion. So this is the age of practice that can be practiced, and when these communities are working or going for some work, also they keep the baby like this. Then use of blinder. Blinder helps and it causes some benefit. When even without blinder also we can start KMC or we can do KMC. Then the third component is the follow-up. I think one of the most important point is that every small or high risk baby should be kept under follow-up. So if you see this, you can remember this ABCD, FG, HIO. You can one is age anthropometry. Every visit, head and appearance and weight, every visit and length every 3 months. That means when the according to the visit schedule, we have to see anthropometry in every visit. 7, breastfeeding. We have to observe any breastfeeding issue, any problem. Then counseling. You can counsel the feeding, hygiene, any small inquiry issue, ask the mother about her concern, any problem at home. Then developmental screening at 3, 4, 8, 9, and 18 months. That depends on whatever chart you are using. You may use DNBAR, you can use Trivandrum screening and fill the chart and refer when needed for detailed developmental evaluation. I think you know ROP screening should be done for all babies who are born less than 2000 gram or less than 35 weeks. And once the ROP screening is completed, you should emphasize on getting ROP screening from a skilled ophthalmologist and also examination at 9 to 12 months. And very, very important that ROP screening is very important. Every baby who are less than 2000 gram or less than 35 weeks or any babies, any some other issues that should be called for ROP screening. Neurosonogram for babies who are less than 1500 grams, one sonogram should be done at 1 to 2 weeks, another is 36 to 40 weeks. Growth monitoring every visit, and another important thing is plotting growth chart. I don't know how many of you are plotting growth chart on the WHO growth chart. Just remember, WHO growth chart should be used once the baby reaches 40 weeks of gestation. Just one point to just remember, the first line, the 0 day corresponds 40 weeks. That means once the baby reaches 40 weeks, then only use the WHO growth chart. Then hearing screening ideally before discharge and complete by 6 months, and automatic auditory brainstem response is preferred. Immunization as per schedule, we know, and others language, speech, behavior, IQ testing at 3 years. Any delay detected should from early introduction. So in summary, what is can be said, KMC and breastfeeding improves neonatal survival. Early initiation of KMC promotes improved breastfeeding, prevents hypoglycemia, and a lot of benefits like it improves weight gain, reduces infection, it improves neurological outcome, also reduces mortality. Foster KMC is a good option to increase the KMC hours. Ambulatory KMC improves KMC hours. Blinders are extremely useful, but without blinder also we can do KMC. So what are the barriers at the hospital and in the community? I think all of you know about the quality improvement initiative. This is the fishbone analysis. The head is the outcome, the poor KMC practice in the hospital. This study was done in a Chinese hospital. Here you have seen parents. What are the problems that they found in parents, sick parents, pain, resistance from the family member. That means you have to keep the family members on board. Loss of work time, though, if the working mother is there. CPAP, central line, phototherapy, even babies on CPAP can be given. Yeah, KMC. Then poor knowledge, shortage, workload, fear of infection, maternal needs, psychosocial problem, lack of policy. Policy is very important because policy, what I think, unless we have got a strict policy, we will not be able to do so. Suppose I have to come at 8 o'clock, otherwise I'll be marked absent. This kind of policy should be enforced in when you are doing KMC. But already you say if you do not KMC, nothing will happen. It's not like that. If a baby is actually less than 2000 or less than 2500, that policy should be that this baby should be given for KMC. Then poor management from poor support from the management, privacy, lack of chairs, place. This is important in actually postnatal ward. Postnatal ward in some unit they have already made some places for KMC and they give priority to babies who are less than 2000 grams or more than 1800 grams. So what are the barriers at the community level they found? They found that social family support, religious belief, it is very important. Once the babies are in the hospital or SNSU, then lot of support is there. You are supporting them, nurses are supporting them, hospital is supporting them. But once they are going home, many parents, those who are born in the public sector hospital, they are not getting that support once they are given. They have to do all household work. They have got little time. So that the family members should be encouraged and to tell that they should continue KMC once they are going home. Then lack of training, workload, work, household chores, this is what I have already discussed, excessive sweat, poor privacy, excessive cold, lack of facility, lack of linkage, place, etc. So these are the some issues that should be discussed before sending the babies at home so that we can remove these barriers when the babies are going home. So lastly, we can finish with a case study. This is a 34-week baby, 2.1 kg, to a gravid one mother. The infant is 3 days old. She is on direct breastfeeding. The infant's weight is 1.8 kg. Mother feels that she has inadequate milk production. On examination, she has engorged breast. I think this is a common day-to-day problem. A mother is coming, first 1 or 2 days, there is no milk, and suddenly third day you find there is engorged breast. She refuses to express milk and does not want to do KMC. Grandmother wants discharge, wants to start the baby on cow's milk. Now tell us what should be done differently. Anyone? And what is the diagnosis of the infant? I think this is a common problem. Most of the mothers, you will, if you go to the postnatal ward, the first 1 or 2 days, they will have enough problem. For they should say that there is not enough milk. But on third day, you will find there is engorged breast. So what we have to say? So it's the same get back. You have to greet the mother. That means you have to sit with the mother, greet the mother, see what is the problem. Then you have to ask the mother has problem or issues. Then you have to listen what is her problem. Suppose a mother is not willing to do KMC, you cannot school the mother. That is sometimes been done. That is dangerous. If you school the mother, that mother will never come. Rather, you have to encourage the mother. So you have that first 2 days, you have not even breastfeeding. That's why there is encouragement of breast. So you have to praise the mothers. Or if the mother has come to you, have to tell the mother, it is very good to see that you have come to me and you want my advice or you want. Second is the listen, then praise, then advice. Then you have to praise that you have to express the breast milk and you have to start KMC. And as I have told you earlier, that if you start KMC, it will increase your breast milk. Babies will have all these benefits. So these advices should be given to the mother. And after that, you have to check what the mother has understood. The, that cross check, that is very important. This cross check is important, I feel, in clinical practice. One prescription medicine. We have prescribed medicine, but patient has not taken the medicine. Then what is the use? The same thing. We have given some advice, but we have not checked the what she has understood or not. So we have to again tell me what I have told you. If she can tell, that means she has understood. And for breastfeeding and adequacy of feeding also, you have to tell this, you have to take the same breastfeeding counseling formula, that mnemonic, that GALPAC, and you have to counsel accordingly. Only one important thing is that you have to spend some time with the mother. But the problem remains that how much time we are spending with the mother. And I told you that more less than 2000 gram or less than 2500 gram, more than 1800 grams babies they are in a postnatal ward. So they need equal help. Just before I finish, let me tell you, if a baby is born 1850 grams, this baby will go to the postnatal ward. If a baby is born at 750 grams, this baby will be in the SNCU. You tell me what is the difference between the 750 grams and 1850 grams. Now I think we all of you agree with me. This 1750 grams baby, the amount of care and will get the same amount of care you will not provide to the baby who is 1850 grams. That is our problem. That's why you should give equal importance to babies who are in the postnatal ward also. So, what are the key messages? Developmental supportive care is a continuous process. It provides a environment which helps in the growth and development of the baby, and it should be started after the birth of the baby, especially for babies who are born preterm. And DSC should be individualized for each and infant. Each and every infant is different, and need is different. Developmental supportive care reduces the stress of the baby and promotes growth and development. And KMC is one of the best form of multinodular stimulation, and it is also one of the most important form or component of developmental supportive care. And developmental supportive care is a low-cost, evidence-based intervention. And I say this development support is a game-changing intervention everybody should follow. Thank you very much. Thank you for your question here. So if you have got any query, you can. I'll be happy to answer. Hello? Hello? Hello, please. I think I can see some. You can write your question in the chat box. I can see some of the question in the chat box. One is that Shayan has a slight now. I think ineffective breastfeeding and insufficient milk transfer. Shayan, what is your question? I think I have given the answer. Most of the time, once you uh, once you go to the postnatal ward, suppose the baby is 24-hour old or 12-hour old, mother is complaining that baby is not getting any milk and baby is crying. So how do you counsel the mother? You have to counsel the mother. See, in the first 12 hours, baby. Sir, please show the slides from the beginning because initial 10 to 15 slide was not moving. Okay.
Strong breakers. Say, golden foundation. Bishop of strong breakers.
Hello, I think if you want, we can actually share the slides afterwards also. Okay, let me see. Is it visible now? Is it visible now? So first I was discussing the protective sleep, pain and stress management, development, supporting a family centered care, creating a healing environment. Then first I talked about the component, then the component out of that, there are another two components, skin care and nutrition. And this was a slide for protective sleep, how we can ensure protective sleep, then prevent and treat pain or management of stress, cluster care adhesive, patient must be educated, unit protocol, normal pharmacologic measures, then activities of daily living, clustering of the care, gentle handling, changing the diaper, not lifting, non-native suckling,
Dr. Bijon's slide is not moving till.
Now it is not moving.
No.
But
You please send in this group.
I think we can send the group in the slide in the group. It is
That
moving
will
in
be,
my.
it is a very nice talk, very nice and very elaborative talk.
I think.
And every points you have cleared.
Sir, I think we can take some questions.
Yes.
You can write in the chat box so that question can be answered one by one. Any questions? Just remember the just two slides I just want to highlight. Developmental supportive care definition, you know, the core component of protective sleep that can be issued by nesting, swaddling, kangaroo mother care, cluster care, healing environment by minimizing slide, maintain SFCs, facilitate smooth transition, family participation care, family centered care by involving the families in the care, counseling and lactation support, educating, activities of daily living like flex posture, non-nutritive suckling and feeding, prevent and treat pain like non-nutritive suckling, swaddling, containment during procedure, and skin care and nutrition. And kangaroo mother care, I think you can see, you would have seen all the slides what I have discussed. Any others, Bhaiya? Oh, who is score for pain management? Let me discuss the score of pain management. Yeah. Hello? Just hold on. Hello, there are various score. Yes, one is neonatal skin condition score, that is NSCS. Am I audible? Hello?
Yes, sir,
Yes,
audible.
yes.
You're audible, sir.
Yes, audible.
Yeah. So one is that one score is called neonatal skin condition score, NSCS. That one is first is dryness. Dryness is one is normal or no skin, no sign of dry skin. Two is dry skin, visible scaling. Three is a very dry skin and crackling and fissure. Then erythema. One, no erythema, no evidence of erythema. Two, visible erythema less than 50% of the body surface. Three, visible erythema more than 50% of the body surface. Third is a breakdown or excoriation. One, non-evident. Two, small localized areas. And three, extensive. I think it's a good question. We are not giving any importance to the skin. So maintain skin barrier integrity. How we can maintain the skin barrier? One is varnish we should not remove. Non-adhesive polypropylene wrap just after birth for babies who are less than 32 weeks. Humidified incubator, emollient and the skin antisepsis for catheter placement, skin to skin contact, assessment of skin core, and educate the caregivers and the parents. That is very, very important. Another important thing is that you should provide appropriate positioning support utilization of gel products sometimes. Examine position of the nasal bronch. This happens especially in the babies who are in the what to say that babies who are in the CPAP, and many times it causes injury to the nose. So if you can take some, you can follow this score. I think that will be helpful. Hello, any others question? Benefits of nesting. I think pain management score is also there. Pain management, there are very well. One score is reverse PIPP score. You can take any score. In many centers, we use a reverse PIPP score. Then benefits of nesting. Nesting is that it is a boundary. Once the babies are kept in that boundary, the babies are in the just like an intrauterine posture. And another important, as I told you earlier, that gravity has got an effect on the posture. Suppose a preterm baby is there and baby's limbs are extended, that will have some effect on the muscle development. And also sometimes what happens if the baby is kept in the same posture in the head, there may be plesiocephaly. So that is so nesting should be made in such a manner so that the baby is kept in the nest, his hands and limbs is not outside the nest. This we have found for preterm baby, it is not a problem. For a little bit bigger baby, if you want to make a nest, so that it should be size should be big enough, should keep the baby inside the nest. Any other? Any other question? I'm very sorry that the first slide was not moving. I thought that it was moving after that, but we can share the slide, no issues. If you have got any doubt, please. How many of you are practicing KMC and hours? Honestly, you speak. How many hours you are practicing KMC and how many you are practicing skin to skin contact in the delivery room? Because these are some game changing intervention evidence we should start practicing. Skin to skin contact. Raise your hand. And KMC. And just tell me how many of you are actually practicing the developmental supportive care. See, in unit we are very much busy with putting IV line, central line, surfactant, ventilation, but these are equally important. Unless you practice this baby will have adverse neurological outcome. So actually, after today's talk, some of the take-home message I think we should carry. This nesting, swaddling, and facilitated tucking should be practiced. Baby should have good protected sleep. Activities of daily living should be followed. Management of pain and stress should be done. Families should be encouraged to participate in the baby's care. Then younger mother care should be practiced, not 1 hour or half an hour, at least 8 to 10 hours. You will find your baby's outcome will improve. And every day you have to practice it. You have to. It is a continuous process. This quality initiative is a continuous process. Once you, it is very difficult to start, but once it starts, it will continue. And if you actually want to sustain it. I think if there are no query, any other queries or any questions, any doubt, or you do not understand, suppose should we close if there is no questions or query?
So there are two questions in the chat box.
There are two questions. Okay. See. Oh, well, how to decrease noise in SNSU? One is, what are the sources of noise in essential? One is all alarm, like your pulse oximeter, multi-channel monitor, ventilator, etc. First of all, we should know what is the alarm limit. Let me discuss first about the oxygen saturation. We know that oxygen saturation, if a baby is more than, in a term baby saturation should be more than 95%. So when you try to set the alarm, you should set the alarm so that 95 to 100. If a baby is on supplemental oxygen, is 90 to 95. Suppose if a baby is on supplemental oxygen, you are keeping the alarm, it's 90 to 95. But baby is saturating at, a baby is on now, initially you are giving 30-40% oxygen, now baby is on 21% oxygen. So once the baby is, now saturation is 99% or 98%, even in 21%. During that time, we have to change the alarm from 90 to 95 to 95 to 100. Second is the volume. You should keep the volume in such a manner so it neither disturbs the baby or also you can hear the sound. So that once there is alarm, you can address what is happening. Second is that multi-channel monitors. It's everywhere. So some heart rate, same thing. You have to set the heart rate in such a way. So accordingly, you can set. Third, volume. Now next is the ventilator alarm. Ventilator alarm, actually why the ventilator making noise? Ventilator making noise is that once you see some alarm, you should see why there is alarm. Suppose it is says the baby is showing is apnea. Apnea. Apnea means, that means if you set the alarm 10 seconds, apnea, after 10 seconds, if the every time it will give the alarm. So you can set the alarm means you should know the ventilator. What are those alarms? How they are changed? What is their limit? How it can be done? That is very important. That is why once you get a ventilator, you should know what are the parameters are there and what is their alarm limit. And you should go to the screen and accordingly you can set the alarm limit. Otherwise, it will go on and giving the alarms. Third is that another important thing is a ventilator like non-invasive mode. Suppose I want to keep a baby on non-invasive positive pressure ventilation. In many ventilator, there are some software. For nowadays, now the current generation, this software is there. So if you use those ventilators, they will not give any alert. But if you are using a ventilator which does not have a software, but you are using that IMB mode, like your Babylog 8000 plus, this has got a mode for CPAP, but not for NIMB. So we use this mode as IMB as the non-invasive positive pressure ventilation. In that case, it will continuously give you alarm. That is one. Second is every alarm you should know. That is why we always, what is should be done once a ventilator is installed, you should know every function of it, and you should know how to actually change the setting. And if you do not know, then it will give you alarm. Despite doing all these things, there may be some alarm, but every time, even after that, sometimes you get some problem. Then you can contact your service person, they can help you. But I request all of you to actually know your machine and know all the parameters and the alarm limit. Then only you will handle reduce the noise, otherwise not. And second is that human nature. Many of us talk in a loudly in the unit, that should be avoided. Then alarm limit of the telephone. Then you can reduce in the low tone, or this telephone can be kept outside. Another is that mobile phone. In our unit, we do not allow the resident to use mobile phone inside the NICU. That should be avoided. So these are the few ways you can reduce the noise in the unit. And nowadays, in many your mobile phone, you can check the actually sound level. Actually, recommended sound level is 45 to 50 decibel. You can see. And another noise area is the incubator. In some incubator, because of motor, there will be some noise. But nowadays, the current generation incubator, the noise level will be very low. Any more question? Some unit has done some. You can do a quality initiative to decrease the noise level in the essential. This is a good QI for QI study. It will be a good QI study. You can make a feasible analysis. Another is awareness. First of all, we are not aware that this noise can cause problem to the baby. So you have to teach and educate your staff about the noise. You have to teach and educate staff about how to set the alarm limit. You have to teach and educate staff how to set the volume limit. You have to teach and educate the staff how to reduce the how to set the alarm limit in ventilator, because ventilator many parameters are there. So unless you do it, it will not be. And whenever you go to the unit, you find lot of alarms. That means nobody is bothered about them. So that is very, very important. And many centers it is going that we go to the unit, you will be mad with the sounds. Any more question? Can you tell me how this KMC reduces the incidence of infection? Anyone? You can write in the chat box. How KMC reduces hospital nosocomial infection? Good, Flora, good. That means this less hypothermia.
देखिए जो भी आएगा ना उसको हैंड ओवर दे दीजिएगा। देखिए ये वाला
हाँ।
पेज है और इसका चूंकि नहीं बना था, हम बना रहे थे, एक्शन अगर नहीं बना था उसमें, और ये वाला पेज
So one is that
हाँ ये वाला एक बीच में बन गया है, ये साइन हो गया है।
So one question is that how to avoid aspiration in newborn.
ठीक है, तो
See,
दोनों बता दीजिए।
just this is a good question. Let me tell you, when a baby will aspirate, a healthy infant will never aspirate. What happens? This is a common practice, or sometimes some mishap occurs in the postnatal ward. You find suddenly baby dies, or there is sudden infant death syndrome, and we attribute it to aspiration. But how it can be? What happens? Suppose a baby is sick, and you fail to actually identify that sickness. Baby is lethargic, poor feeding, not able to swallow, and you are allowing babies either case feed or breastfeeding, etc. So what happens? So the baby will aspirate. Second is that normally in a clinical condition like your baby is having tachypnea or respiratory distress, there is a chance of aspiration. But in those infants, if the baby is hemodynamically stable, we can give feeding, enteral feed by OGT. So, but one thing is that I think if we carefully see the babies, daily monitor the baby, you will identify the sickness of the babies and you can avoid aspiration. That is why I tell all of you what you should do in the postnatal ward. This happens in the postnatal ward mainly. And postnatal ward, I am sure all of you are giving round morning and evening. That is very, very important because majority of the babies who are more than 1800 grams, they will be in the postnatal ward. So if you do not go there and you try to address the problem, then this mishaps will keep on happening. Otherwise, aspiration should not occur. Because if the baby is sick enough, we will not feed the baby. If the baby is having distress or hemodynamically stable, not able to swallow, then we will give OZ feeding. As you know that if the baby is more than 34 weeks, baby can directly breastfeed. 30 to 34 weeks, baby may swallow, but baby may not suck. So in that case, you can give AS feeding. Less than 30 to 30 weeks, you can give OZ feeding. But another important thing is that gestational age. You should know the gestational age of the baby. Why gestational age is important? Because Suppose a baby is born at 30 weeks of gestation and baby is in the SNCU. So initially we have kept the baby on OZ feeding. So after 2 to 3 weeks, baby gestation will increase. So by that, actually baby should swallow. So during that time, we have to start KS feeding. And after another 2 weeks, this baby should actually on direct breastfeeding. But unless you know the gestational age, how can you do all these things? Many times it is seen that gestational age is not written. That the correct gestational age, not term and preterm. Term means more than 37 weeks of gestation up to 42 weeks. Preterm means any baby less than 37 weeks. So we have to write the correct gestational age, and there should be access in the delivery room. Unless you do this thing will keep on happening. That is why you will find many times in a unit, what happens? Baby is there for 2 months and baby is on OZ feed. Nobody knows what is the gestational age. So that's why correct gestational is very important. And as the baby grows, you should know what is the correct gestational age. And according to you should plan your feeding. Because for feeding, three things are important. One is gestational age, second is hemodynamic stability, and third is neurological status. If the baby is neurologically stable, baby will not aspirate. If the baby is hemodynamically stable, baby will not aspirate. If the baby is more than 34 weeks, or more than 32 weeks, baby will not aspirate. So if there is aspiration, that means there is some problem along with this. Suppose the baby was not, suddenly baby is sick. So another important thing of aspiration is the asphyxiated infant. Many asphyxiated infant, they have got advanced neurological outcome. This baby cannot swallow. So there is risk of aspiration. So that is why it's very important. You should know the gestational status, you should know the hemodynamic stability, and also neurological status of the baby and any sickness. So if you know all these things and carefully monitor the baby, you can avoid aspiration. Another important thing was even the baby is sick or some neurological problem is there, as I told in my discussion, you can start oromotor stimulation or non-nutritive suckling. We did a randomized control trial in our unit. We found that oromotor stimulation actually it really helps the babies to achieve enteral feed. So these are things you should practice. Any other question? Just tell me how many KMCs you are practicing KMC both in the SNSU as well as postnatal ward, because postnatal ward is neglected. SNSU anyway, mother will be there, baby will be there, some nursing staff will be there, staffs will be there, consultant will be there. What about the postnatal ward and community KMC? That is very important. What is containment? Tell me what is containment? Let's write in the chat box. What is containment? And how does it help? Containment is that actually you are practicing this containment. Once you are doing some procedure like lumbar puncture. So you actually flex the baby limbs and you hold the back of the baby with your hand and put one hand over the head so that baby feels secure and it will reduce the pain. That is why containment. Containment and facility time is almost same. So you should not get confused what is nesting, what is swaddling, what is facilitated tucking, and what is containment. Are you practicing giving colostrum to the baby immediately after birth? How many of you are practicing colostrum feeding? Please. And skin to skin contact, how many of you are practicing in your in babies who are born in the delivery room? Anyone? Can you tell me what is the difference between skin to skin contact in the delivery room and KMC? Please write in the chat box. Please write in the chat box. What is the difference between skin to skin contact in the delivery room and kangaroo mother care? See, skin to skin got two on all gestational days and table baby. Any more? Any question? Any other question? Answer? Thank you, Sneha. Uh, KMC to preterm and LBW, yes. Or see, skin to skin contract should be, as we know that every baby should be delivered over the mother's abdomen. And after deliver the mother's abdomen, you start drying. And if the baby is breathes or cry, baby will require routine care. And one of the component of routine care is skin to skin contact. So that means any baby born and of any gestational age and does not require resuscitation, they will be given skin to skin contact. And this skin to skin should be given for at least 1 hour. But kangaroo mother care, as you have rightly said, should be provided all low birth weight infant and who are stable, irrespective of their gestational age. Another important thing, just tell me, once you give skin to skin contact, why baby, why 1 hour is very important, and you should initiate early initiation of breastfeeding within this 1 hour. Why? Because during the first 1 hour of life, baby's sucking reflex is vigorous. That is why you should allow the baby to suck. And during the time, if you those who are practicing skin to skin contact, you will find the colostrum comes out. So one of our staff, they say that once baby is put on the mother's breast, so one benefit is that my skin to skin contact and early initiation of breastfeeding, and also once you keep the baby to the mother, the attention of the mother goes to the baby. That's why mother feels less pain also, and also there is oxytocin hormone secretion, the postpartum hemorrhage also. So you are right, the skin to skin for all gestational age achievable. And somebody has written about the burping. Actually, burping is not required for all babies. It is said that if you give the breastfeeding, then you can burp the babies. You cannot, burping is not required. Many says that baby can take some air for that. If there is no problem, there is no issues that every time baby should be burped. And only thing you should go and do something if there is some problem. If there is no problem, just ignore. Any question? Can you tell the sequence of sensory development in neonate? Which senses first develop? The sequence, how it goes. Out of all, tactile, vestibular, olfactory, gustatory, auditory, and visual. Which is the first one? Please write in the chat box. I think actually nesting you can keep for both term and preterm, but mostly it is the preterm. Any sick baby you can put, but for term baby you need a bigger nesting. Not auditory. It is a tactile first. First tactile. Then after tactile, what? Vestibular. After vestibular, which one? It goes like that. First tactile, then vestibular, then olfactory, then gustatory, then auditory, then visual. It goes like that. Tactile followed by vestibular, then olfactory, then gustatory, then auditory, then visual. Somebody says this is not oxygen hood or nasal cannula. Which one is preferred? See, WHO says oxygen is not preferred over the nasal cannula. Why? It is saying that in oxygen hood there is some mishap. In the oxygen hood, suppose for some reason this oxygen tubing is out of the hood, there will be retention of CO2. That means cause damage to the that may cause death to the baby. But nasal cannula there is not. So always it is nowadays many centers they have stopped using oxygen hood. Sometimes there it may happen that somebody has stopped the flow meter, so that will also kill the baby. And in the studies have shown that in many places there is history of some mishap because of oxygen hood. So nasal cannula is I preferred over oxygen hood. As I told you, what is the effect of gravity on the muscle? It is said that there will be underdeveloped flexor tone and also absence of musculoskeletal support. So that will cause scapular retraction, hip abduction, and cranial deformation. You told about the noise reduction. Some other activities can be done, like gently open the door drawers that I have already told, prepare the medication and feed away from the bedside, equipment noise reduction that I have talk softly at bedside. So these are the ways you can have less. What is octopus care? Can you tell me what is octopus care? Octopus therapy? Wrapping means that swaddling is the wrapping actually. Wrapping of the baby in different layer, that is the swaddling. Nesting is the boundary. Facilitated tucking is the keeping the baby flexed and should be in the midline. That is facilitated tucking. Wrapping is actually that is swaddling. As octopus, sir, from why to read this all these things you said. Actually, I think the study material it has been sent. There is something is there, or I think I will send the slide or some of my slide to you. This is one slide. Another presentation is with me. I'll send all this presentation to all of you so that you can get the idea. I have got two, three presentations I can share, and that will have you can have better understanding. You can read that study material what has been given. I think I know facility-based newborn care and there's a preterm care package module. There it is written. And this presentation is made based on this. One is facility-based newborn care module and the preterm package module. I think it is all available. It is available. And I can share the slide to all of you. I'll share. Anything? Octopus therapy is actually being practiced in Finland. Actually, before initiating the octopus is put through the, or it is just made of octopus made of wool, and it is put through the baby through pamper mother care with the mother of the preemie about 10 to 12 hours. So what happens? The baby will try to actually take the tentacles of the octopus, and that will get the feeling of that handling the umbilical cord in utero. After the completion of PMC section, the octopus is placed next to the infant in an optimal position as designed. And maternal body odor is transferred to the octopus during the process. How does decrease the burden of necrotizing enterocolitis in the NICU? See, the one of the most important thing, the best medicine is breast milk. You try to give breast milk in the NICU, that will reduce the decrease of necrotizing enterocolitis and prevention of infection. These are the two main culprits. So, expression of the breast milk and try to feed the baby with the mother's milk and prevent infection. That will decrease the burden of necrotizing enterocolitis. Any other? Anything you could not understand, just tell me so that we can clarify. Any issues? Anything you want to know? Think before we end, actually, let me tell you, all of you. So, these developmental supportive care and kangaroo mother care, these are evidence-based practices that is really helpful for good neurological outcome to a baby. But unfortunately, these are the small things we do not actually try to practice in our unit. So, first of all, we should believe ourselves that these practices are helpful for the baby, so we can make changes in the neurological outcome. Unless we believe ourselves, how can we change? So I request all of you, whatever we have learned in this neuroscience program, you try to implement those things in your day-to-day practices. Once you start practicing all these things, this will have good effect. So knowing is not enough. We have to implement into our clinical practices. And these are the practices. These are low cost. I think not low cost, no cost intervention. Only thing we have to start implementing. So that's why we need awareness. You try to aware your people. You can see these videos, see this presentation to your staff, so that they can do. Once it is very difficult because nobody bothers about all these things. So once you start practicing, definitely people will be interested to do all this. I think this will be helpful for all the things. As we have said to read all these things, I think I will share my two PPT in the group, in the e-zone group. So that will help you. That's what this preparation. See these PPTs. I think Shweta, if there is no question, we can call it a day. We can wind up the session. Thank you very much. Thank you for your patient hearing. I hope whatever we have discussed today, we will be able to implement these things in our clinical practice. Good night. Shweta, can you hear me? Hello? Hello?
Yes, sir. Am I audible?
Yes, you are audible. I think if there is no question, can we wonder today?
Definitely, sir.
I think there is no question. Thank you very much for the support. Thank you all, and thank you for patient hearing. And there
Thank
was a
you so much.
little there was a little bit of problem because of changing of the slide. I think we can share the slide so that everybody can get access to those slides. Thank you very much. Good night.
Thank you so much, sir, for extending us the opportunity to host the session. So, with all your permission, I would like to conclude the session over here and looking forward to host you again. Thank you, sir, and good night.
Good night.